68-year-old with ulcerative lesion, and it was initially red and not painful, and there is a puncture wound and cigar-shaped yeasts are being found, is a classical example of Sporothrix schenckeii. Sporotrichosis is what you have to remember, and itraconazole orally is considered to be the management of choice. A 19-year-old young sizzling college girl from Navi Mumbai had a yellow mucopurulent discharge from the endocervix, and she has a history of multiple sexual partners for the past 6 months. So what is the possible diagnosis? Possible diagnosis is gonococcus. To discover it, it is the Thea-Martin medium, which is the one which is basically used for the discovery. So where do we use McConkey doctor for the Enterobacteriaceae, E. coli, etc. And Hectoin enteric agar is the one which is used for Salmonella and Shigella, is what you need to basically remember. There are about some 16 topics in microbiology. 90% of times DNB primary questions only come from those 16 topics. I will show you what are all those 16 topics, how it is 90% of times only from them when we when you come on October for the class. Now, there are various antiviral drugs. What is the mechanism of action is the question. Basically, formation and release of the daughter virions should happen first. Then, if you look at the acyclovir act at the level of mRNA polymerase of the host cell, utilization of that is the one which is affected. Uncoating of the virus is affected by hematidine, and ribavirin basically acts on the viral RNA polymerase, and neuraminidase inhibitors are important that prevent the release of the daughter virions. That is how the site of action of the various antivirals. You have to be 100% sure when you go for the tomorrow's exam. Cardiac biopsy has been done, and immunohistochemical staining has been done. So there is a birefringence on congruent staining, which means amyloid cardiomyopathy. Then transthyretin protein is shown in abundance. So different types of amyloidosis are there. Each amyloid has its own special and a peculiar type of amyloid protein. That table in Robbins pathology or whichever the book Davidson, you must be 100% sure. Amyloidosis is 6th or 7th very high yield topic in pathology, frequently asked. Okay, so you have to be 100% sure. So neurocognitive testing is something that you basically need to do in this given case, because in Alzheimer's disease, whenever amyloid get accumulated, that typically accumulates in the heart, and also the transthyretin protein typically will be positive, is what need to be remembered. There is a fatigue and sore throat in a patient. Bone marrow biopsy has been done. I am very happy to see 25 online viewers and many more from the different centers. Rutika, Saurabh, Guntur, Harika, everyone. 45-year-old has fatigue. So bone marrow biopsy is shown. It is a classical example of granulations which you are seeing in the cells now. So acute promyelocytic leukemia will have this kind of granulation containing myelocytes. So typically what is the type of chromosomal translocation in APML? It is 15-17 is what you have to be very sure. Remember, doctor, the 4 leukemias, ALL, AML, CLL, CML, and Hodgkin's and non-Hodgkin's lymphoma, and hairy cell leukemia. Without that there is no paper. Definitely 1 or 2 questions will come. Whether in pathology or pediatrics or general medicine, everywhere you have leukemia, lymphoma. So if you have not made it a point in your list that anything comes on leukemia, lymphoma, I am happy to see, because I am ready for any kind of question in these topics. That must be your definitive approach for winning. Okay, doctor. By the time it is December, you must be ready. 90% of paper should be predictable for you. There should not be any shock. If a boy says, I love you, why only me? Then he says that all your classmates rejected, that's the reason it is you. So, that kind of response should not be there when you look at the question paper. Why only me, lymphoma, leukemia came? It is because you, lymphoma, leukemia came. Huh? So, definitely it will come. Now, doctor, 35-year-old undergoes physical examination. She is having progressive dyspnea, elevated JVP, fixed split loud second heart sound. Do you need to really look at X-ray also? Not really required. ASD must be there in your mind. Okay, it is a case of Eisenmenger syndrome developing in a case of atrial septal defect is what need to be remembered. If you look at ASD, VSD, PDA, what is common to all these three? In all these three, there is a left to right shunt. Hence, they are acyanotic. That's the reason all the left to right shunt will bring more blood to right side. All that blood will go into lungs. Hence, pulmonary plethora is what you find in ASD, VSD, PDA. Pulmonary oligemia, where will you find? Tetralogy of Fallot, because there is a pulmonic stenosis. Tricuspid atresia, because right-sided stenosis is there. Pulmonary oligemia will be there. Epstein's anomaly, since there is an abnormal position of the tricuspid valve, there is a development of a pulmonary oligemia. So that's what you need to understand. Yes? Because in the earlier case, there was a Eisenmenger syndrome which has developed in ASD. That is the reason cyanosis has developed in this patient. Huh? That's the point. Now, you are examining a new patient. There is a harsh murmur. It is best heard in the apex, and there is no respiratory variation. That means left-sided murmur or right-sided murmur. If there is no respiratory variation of the murmur, come on, right-sided murmurs vary with respiration. Left-sided murmurs do not vary with respiration. Okay? When you go to anatomy-to-medicine.com, even if you are not enrolled, try us free bolke. There will be a lot of free videos. In the dynamic auscultation of murmurs bolke, there is a 30 minutes review lecture. Dynamic auscultation of murmurs. What is the effect of increasing preload, afterload, variation in the preload and afterload on the murmurs? How to differentiate MVP murmur from HOCM murmur? What happens if you give amyl nitrate to the murmur of HOCM and MVP? All this funda. If I start going back into that tempo of revision of all those things, we don't end. We will end only with them. So that's the reason. Please review that. Otherwise, in cardiology, in anatomy-to-medicine.com video library, you have got dynamic auscultation. So in this case, what exactly is happening? Patient is having basically HOCM. Anyway, I have an inborn error of teaching like metabolism. So if I don't tell you why HOCM murmur, how does it vary with amyl nitrate inhalation? Who will tell you? Nobody else will tell you unless I tell you. So doctor, you are having mitral valve leaflet. You have interventricular septum, and from the left ventricle aorta is arising. ये तीनों रहने वाला चौरस्ता होता है ये LV outflow tract, right? इधर से left atrial blood goes into left ventricle, और इधर से left ventricular blood goes into aorta. And the same place, mitral valve leaflet, anterior leaflet will be touching the interventricular septum, which is hypertrophied. That is the reason when interventricular septum touches the mitral valve leaflet touches the interventricular septum, which is hypertrophied, the left ventricular blood cannot freely go into aorta. It is as good as having aortic stenosis. But here the obstruction is below the level of the aortic valve. Aortic stenosis is at the level of the aortic valve. Hence aortic stenosis which you get in rheumatic heart disease is called valvular stenosis. This is called subvalvular obstruction, is what you need to remember. Now what will happen if you give amyl nitrate? Amyl nitrate is a venodilator. Whenever you give a venodilator, the blood gets accumulated in the peripheral veins. So the blood returning to the heart will decrease. Whenever it decreases, the preload decreases to the heart, and that will decrease the filling of the ventricle at the time when it was filling. That will make the ventricle size become smaller. When it becomes smaller, the touching becomes more, and that will increase the obstruction. Hence, amyl nitrate by decreasing the preload will lead to increase in the obstruction, is what you have to basically understand. So, remaining things you can review in the online video library. So, it's a case of HOCM that alters is what you need to remember. With amyl nitrate inhalation, it basically worsen. What will happen with standing? When you stand, all blood accumulated in the periphery. The amount of blood coming back to heart is decreased. When it is decreased, the chamber size decrease, touching more, and that will worsen the obstruction. What happens to Valsalva maneuver? Valsalva means forced expiration. With inspiration, what will happen? When you inspire air, there is a negative intrathoracic pressure. When you give me the board. When you have inspiration, what will happen? There is a negative intrathoracic pressure. When negative intrathoracic pressure is there, blood is sucked into the heart. It has the sucking ability. Negative pressure. Hence the filling will be more. What is Valsalva? Opposite to inspiration. Forced expiration against a closed gratis, which creates a positive pressure in the thorax. If inspiration increases venous return, what will expiration and Valsalva will do? Decrease. If inspiration has a sucking ability and increase the venous return to heart, opposite to inspiration is Valsalva maneuver, which is expiration. What it should do? Decrease the venous return and decrease the ventricular size and increase the touching, and HOCM murmur will worsen. So what will happen to HOCM murmur on standing? Increase. With Valsalva, amyl nitrate, increase. All the three will increase. What will happen with squatting? Whenever you squat, then you are squeezing your vessels and pushing more blood back to heart. Whenever more blood comes back to heart with squatting, venous return, the ventricular size will increase, touching will be lesser, and HOCM will be lesser, murmur will be lesser, is what you have to fundamentally understand. Now doctor, let's go to the next question. There is a long-standing cardiomyopathy with worsening dyspnea. Apical S3. S3 is a marker of ventricular failure. S4 is a marker of atrial gallop, it is called, not failure. Whenever ventricle is hypertrophied, it is not compliant to get filled. Atrium has to use a lot of pressure to push the blood into ventricle, and whenever atrium has to use more pressure to push blood into ventricle, it will make a sound which is called fourth heart sound, S4. S3 means whenever ventricle fails, some blood remains inside the ventricle because it is unable to pump into, failed ventricle cannot pump the blood into root of aorta. Into that ventricle which is already having some blood, when atrial blood jumps into it, it will create a splashing sound, that is called S3. S3 is a sign of ventricular failure. S4 is a sign of, don't tell, atrial failure, ventricular non-compliance and hypertrophy. So that atrium's effort to push the blood into a non-compliant ventricle. So when is S3, S4 are happening? During ventricular systole or diastole? During S3 and S4 are what kind of sounds, doctor? They occur after S2, hence called S3, S4. They don't occur before S2. After S2 is called diastole or systole. Come on, doctor. 4.5 years of medical school. We also learnt it after joining MD. Don't worry. Abhi to baate banate. In our days we did like that. In our days we did not do anything like that. Right? So, yeah. S1, S2, S1. Between S1 and S2, what is it called? Systole. Why do you call? S1 means closure of mitral valve. After mitral valve closed, what will ventricle will do? Mitral valve closed, what will ventricle will do? Ventricle will contract and push blood into aorta. Hence, ventricular systole begins after closure of mitral valve. Closure of mitral valve produces S1. Hence, ventricular systole occur after S1. At the end of ventricular systole, who will close? Aortic valve close. Hence, closure of aortic valve is called S2. So, systole begins with the S1 and ends with the S2. After aortic valve closes, who will open? Mitral valve, and blood will flow from atrium into ventricle. Hence, after aortic valve closure means after S2, what is happening? Filling of ventricle is happening. Hence, after S2, what is it called as? Diastole. And where is S3, S4? After S2. And why will S3 will occur? Typically, if you take the heart, if the ventricle fails during the time of systole, it is unable to pump the blood into aorta. So, some blood remained in the ventricle. So, when the diastole occurs, in the beginning of diastole, when the blood jumps into ventricle, it will produce that splashing sound, which is called S3. And hence S3 is a diastolic sound which occur after S2, and typically it is an indicator of failure of ventricle. Then why will you listen S4? During last 1/3 of the ventricular diastole, atrium actually contracts and pushes the blood into ventricle. But if the ventricle is hypertrophied and non-compliant, then it has to use a lot of pressure to push the blood into the ventricle. And whenever it is trying to do that, it produces what is called S4. So S4 is also occurring during ventricular diastole, last 1/3 of ventricular diastole, and it is a sign of ventricular non-compliance. And it is produced by whom? Atrium's effort. Hence called S4 is called atrial gallop, S3 is called ventricular gallop, S3 is because of ventricular failure, S4 is because of ventricular hypertrophy and non-compliance is what you have to basically remember. So what is meant by passion? Passion means even if you have a vocal edema, even if you taught it 110 times earlier, still with the same emotion, if you can teach to every new student who arrives, that is called passion. What is passion to do surgery? When you have varicose veins, grade 3 hemorrhoids, still you are able to stand and do a surgery at midnight 1 o'clock. That is called passion. So remember one thing, will I do good in microbiology? Will I do good physiology has any future? Why there is no future? If you teach good physiology to students, tomorrow they will become good cardiologists. Am I right or not? So if you have really passion to do that, do it. If you have a passion to not to see 100 psoriasis patients and another 1000 fungal patients who are having itching in their groin, hours together sitting and writing same steroids, same antifungals. If you have passion for doing that, take dermatology. First thing is, do I have passion to live with this or not, is the first question when you go tomorrow for counseling. Okay? If you have passion, you can do anything. Now doctor, unfortunately I had a passion both for teaching and treating. So when two passions are there, you can't do both. So that is the reason, in a very painful manner, I slowly dwindled out from seeing 100 patients to 70 patients, 50 patients, 30. Finally, I am seeing 10 or 15 patients. That too not for money but for only diagnosing that rare things which my colleagues miss. Only for that. Kick. Right? But actual kick I get in teaching, honestly. So passion is all about it. So doctor, what this patient is having is only a left-sided pleural effusion without pulmonary edema. So what is the clinical scenario which lead to such a kind of presence of only left pleural effusion? Always whenever left pleural effusion is there, look for any congestive heart failure. So chronic congestive heart failure is the typical scenario where it happens, and clinical examination may not be able to prove any pulmonary edema in the patient. So because there will be no pulmonary edema but still only left pleural effusion whenever chronic CHF is there, is what you need to remember. Now 64-year-old from Tirupati, advanced cardiac life support, people have arrived. Within 2 minutes of collapse, he was going to Lord Venkateshwara for a darshan, and on the monitor you found, what did you find? You found ventricular fibrillation. So what do you want to do? So immediate defibrillation, 300 to 360 joules followed by CPR for 60 to 90 seconds before additional defibrillation is considered to be the clinical management, is what you need to basically understand. A 24-year-old male seeks medical attention for the recent onset of headaches. 185 by 115 is the blood pressure. Heart rate is 70 per minute. Fundoscopic examination is being shown. What do you see? Arteriovenous nicking. AV nicking it is called as arteriovenous nicking, which is typically seen as a sign of hypertensive retinopathy is being found. His right arm, left arm have high pressure, right thigh, left thigh have got low pressure. So typically, what is the possibility in his given case? Coarctation of aorta, which is identified by doing MRI of thorax, is what you have to basically understand. A patient has got a worsening dyspnea. He had a HRCT which is showing interstitial lung pathology. So which interstitial lung disease is not associated with smoking is the question here. So fundamentally, if you look at the bronchiolitis obliterans with organizing pneumonia, BOOP, it is not associated with smoking is what you have to emphatically remember. For a 60-year-old male, 2 weeks of productive cough, chest radiograph is being shown to you. What is it showing? A cavitating lesion which is typical of pulmonary abscess, lung abscess. You know there is a difference between lung abscess and empyema. I didn't know until joining MD, honestly. So still I topped the state because entire state maybe that time was not knowing. He is much worse than me. So maybe that is the reason. Today if I write I may not even qualify for entrance, that's a different thing. So let me tell you, sometimes competition will be so heavy you can't help it. That particular batch when you have written the exam, there may be too many people who failed last time and very competitively reading. You may be clean bowled. But after another 1 to 2 months you may write JIPMER and you may be in the top 20 ranks. So that is the reason last entrance and this entrance, never there is a comparison. Every entrance is its own. Of course, if you are serially failing in all entrances, you have to rethink. That because of competition you are not losing, it is because of you are losing. That's what you should think. But otherwise, sometimes suddenly competitive ho jata. Suddenly, sometimes you will think this fellow is a moron, he won't qualify, he is at amoebic level of PG preparation. Suddenly he may turn out to be not amoeba, cylindrata, but a complete homo sapien, and top 10 ranks he may be there, one of your friends in the reading room. Competition. That's the reason ultimate rank is decided by competition. Not absolute knowledge always, but you should have working knowledge in all topics, that's the idea. What is this lung abscess? Give me the board. So, there are two things, doctor. You have lungs, you have pleura. In the pleural cavity, if the pus is there, you call it as empyema. Inside lung parenchyma, if it is there, you call it as lung abscess. What is the treatment here? You will put one intercostal drainage tube and drain the pus. Pus anyway should be drained. Of course, also give antibiotics. But if it is lung parenchyma inside an abscess, not in pleural cavity, where will you put one intercostal drainage tube and poke into lung? You can't do that, no. So their only treatment is antibiotic. And you need to treat the patient. And what is the role for surgery in lung abscess? Suppose if lung abscess happen to percolate to the overlying skin, empyema necessitans, or lung abscess which is metastasizing or formed a fistula to the overlying structures, they become indication for surgery. Otherwise, lung abscess per se is medically managed by giving appropriate antibiotics, is what you have to basically appreciate. So that is the reason what will you do? You will give clindamycin. Anaerobic organisms are very common, and clindamycin is the best treatment. A 25-year-old comes to surgery, suffered postpartum hemorrhage. Few weeks she is feeling increasingly tired. Blood pressure is low, 100/60. Pulse is 62. Anybody whose blood pressure constantly low, especially diastolic pressure, if it is constantly low, what does it indicate? There is a insufficiency of mineralocorticoids in the body. Mineralocorticoid deficiency. You should think of Edison's, where predominantly glucocorticoid deficiency is there. So Edison, not Edison, it's not called Edison. Edison means autoimmune destruction of adrenal. We should use the word adrenal insufficiency should be suspected whenever patient is having constant diastolic hypotension. Okay, doc. So there is a hypotension, and neuroimaging was done, which is showing typically the pituitary, which is supposed to be showing a high signal intensity, because it is infarcted. It is showing a low signal intensity, and the surrounding rim of pituitary capsule only is seen, which is a sign of hypopituitarism. So hypopituitarism in the background of postpartum state is basically considered to be what? Sheehan syndrome is what you have to basically remember. A 65-year-old from Guntur is brought to emergency room after her daughter is found to be incoherent earlier today. Her past medical history is hypertension, hypercholesterolemia, COPD. She was evaluated 2 weeks previously for a transient ischemic attack, and she is currently using clopidogrel and aspirin, and her BP is 156/99, and she has got a scleral icterus also. So there is a transient neurological, focal neurological deficit with a transient ischemic stroke, along with scleral icterus, and typically there is a presence of thrombocytopenia. Platelets are only 42,000. So how will you fit all these things into a common picture is a very, very important question. And her creatinine is elevated. So renal dysfunction, hemolysis leading to icterus, presence of what? Focal neurological deficit along with thrombocytopenia. Have you heard something in a MCQ book? Raynaud's pentad of thrombotic thrombocytopenic purpura, it is called as TTP. Generally TTP follows after a diarrheal episode or a respiratory illness, but TTP can also be drug induced like clopidogrel. So it's a case of clopidogrel drug induced thrombotic thrombocytopenic purpura is what you have to basically appreciate, because putting all together. What is the summary? What else did you find in the peripheral smear? This is enough for you to diagnose. Cystocytes, broken fragmented RBCs because of the microangiopathic hemolytic anemia is what you have to basically remember. So you need to basically discontinue clopidogrel and initiate plasmapheresis, and you need to clear all those clots, fibrin free clots, which are platelet rich clots, is what you have to get rid of from her plasma. Is the treatment of TTP is what need to be remembered. Don't worry, TTP HUS we discussed in the online video library. It is available. So just go click and then have a review is what need to be remembered. So if you have only joined for mock tests, you need not hesitate, you can call our helpline for a small additional fee. They will give you access for online video library, because we are more student centric. We are more happy when more people happen to use the online video learning resources. So that is the reason our people will be more than happy to help you if you really require, because there are about 1700 hours of review lectures covering everything on the planet Earth out of 1800 high yield topics. So any topic which you feel weak, you want a revision, click, you have got a pocket sized teacher available in your apron pocket who can review you. Even on mobile phone you can review video library. So but please do something, but complete revision of all the topics. That's the most important thing. And those which are really ignored topics like cerebral circulation, brainstem stroke, anti-seizure drugs, Parkinsonism drugs, migraine drugs, antipsychotic, antidepressant classification. If we didn't read and we want to keep it, we will read sometime, that sometime doesn't come in this lifetime. Let me tell you. So that is the reason you should quickly wash the linen. That's very, very important. So 46-year-old with new onset ascites. Doppler was done, which is showing hepatic vein thrombosis. So what is, there are no cystocytes. What is the possibility in this given case? There is elevated serum LDH, hemoglobinuria, elevated reti count. So in view of all these things, what explains all the combination can explain you. So basically it is a case of PNH, paroxysmal nocturnal hemoglobinuria, is a prothrombotic state. The other part of the picture explains that PNH features, because there is a hemoglobinuria, ongoing hemolysis happening. There is a elevated LDH, which is a sign of hemolysis, reticulocytosis, sign of hemolysis, hemoglobinuria because of the hemolysis which is intravascular. In addition, there is a prothrombotic state like a hepatic vein thrombosis, as what you can see. The combination can only explain the presence of PNH, is what you have to fundamentally understand. Now doctor, for example, a PNH patient, what do you expect in reti count? In a PNH patient, what do you expect reti count to be? High or low? High. Because there is an ongoing hemolysis in the vessels, still bone marrow is functioning, it will try to compensate that hemolysis by creating reticulocytosis. But suddenly in a patient of PNH, you found reticulocytopenia. What is the complication of PNH that has led to that? One of the complications of PNH. Come on. Let's ask our online classmates. Please punch Harika, Vijaya, Abhiram, Surya Prabha, Gautami. If there is a reticulocytopenia in a case of PNH, which complication of PNH you should basically suspect? Any reticulocytopenia, you will suspect only one complication. What is that? Huh? Super. Please give one big clap, doctor, big clap. Huh? Are loud? You don't want to answer, you don't want to appreciate your friends answering. Huh? That's good. Oh, Vijay Reddy said SLE. No. Reticulocytopenia in a case where you are expecting reticulocytosis instead. PNH at one point of time can become aplastic bone marrow, and that time you will develop reticulocytopenia, is what you have to basically, but good try from Vijay. Now doctor, 24-year-old from Trivandrum, arthralgias, morning stiffness, and there is a rash on the neck which is laciform in nature, like a net-like pattern, and arthritis with a laciform rash. What is the important entity that you will basically suspect? Parvovirus infection in adult. In children, clapped cheek appearance is there, no parvovirus. Same thing in adults will lead to a net like rash along with arthralgia. Sometimes it also can lead to a plastic crisis is what you have to basically appreciate. 17-year-old girl, never overweight in the past 6 months, determined to reduce her weight. What is this classical appearance of? Anorexia nervosa. In anorexia nervosa, what happens? Which hormone basically will elevate? Cortisol levels fundamentally elevate is what you need to remember. Now there is an intubated patient who is recovering from a stroke and chest radiograph is being shown to you. And what are the various maneuvers by which you can prevent this from developing? What did he develop first of all? Aspiration pneumonia. There is a consolidation on the right side of the chest radiograph. Okay. So what prevents? Post ligament of treats feeding, elevating the head, combined enteral and parenteral nutrition. There are all the various maneuvers by which you can prevent the development of aspiration pneumonia is what need to be remembered. Not option C. You are seeing a pediatric patient admitted with a constellation of symptoms of diarrhea, alopecia, muscle wasting, depression, and what did you find? You found anogenital area, perineal area and face. A very severe excoriating rash which is basically called acrodermatitis enteropathica. Because pathology is in the gut, there is a development of diarrhea. Acrodermatitis enteropathica is a zinc deficiency, and in them you will also find presence of hypopigmented hair is what I want to underscore to all of you. A primigravida uterine fundal height is being shown at the level of umbilicus. If it is at umbilicus, what is the expected gestational period? 20 weeks. At each level, like a seasoned gynecologist, obstetrician, you must remember, doctor. Obstetrics may, if you do one question wrong out of 30, the chance of going behind others is 10 to the power of 2. 100 ranks behind for every question. Right? 10 questions you did wrong means already 1000 ranks you are behind. In obstetrics, if you do one question wrong in general medicine, the chance of going behind is only 20-25 ranks. Like that, for every subject there is a weightage of you are permitted to lose questions but not in some subjects, right? So because ultimately at most you can lose 30 while coming from shop to home, 30 eggs can fall down and break. If all eggs are broken, mom will never excuse it. So you must carefully walk. 160 out of 200, doctor. If you are scoring, you can happily sleep until results come. If you are at 130 or 40, don't worry. Take a break because anyway you need to prepare for next time. Whole problem is between 140, 160. If you are hanging, your life is decided by others' life. So that is a simple story. Anyway, if you are 100, 110, oh, please come. We are also there anyway. We will be available for the next batch to start preparation along with you. Okay. So that's a simple game. Umbilicus means 20 weeks, doctor. If 20 weeks is according to the clinical examination and 3 months amenorrhea. 3 months amenorrhea is 3/4 the 12 weeks. So it is bigger than what you expected from amenorrhea history. So what are the various causes for it? Multiple pregnancy, molar pregnancy, pregnancy with fibroid, but not acute hydramnios, because generally acute hydramnios has a cause of disproportionate clinical examination and menstrual period as a cause of the discrepancy. It is only suspected during second trimester, but what we are talking is first trimester still, is what need to be basically remembered. Now there is a lateral radiograph which is typically showing the herniation of the contents of the gut into the thorax and the posterior aspect of the thorax. So it is an example of what? It is an example of Lakh's hernia, which is a posterior lateral hernia. How did you know it is posteriorly herniating? Front is ribs, back is vertebrae, and herniation is happening from the back towards back, posterior lateral, hence Lakh. So that is the reason it requires an emergency repair, is what you need to fundamentally appreciate. The severe vomiting, retching spells punctuated by substernal pain comes to emergency room 4 hours later. Esophagogram is showing the presence of rupture of the esophagus with the air seeping into the mediastinum. It is an example of a pneumomediastinum. So what you basically want to do in this case, immediate thoracotomy, it is an indication, is what you have to basically appreciate. Now coming to the lesion, what is this called? Solitary pulmonary nodule. When do you call solitary pulmonary nodule? Typically it is around 4 centimeters in size, and you don't need always excision of mass is not required. You can do a CT guided FNAC, and based on the radiological features, depending upon the doubling time of the lesion, comparing the old radiographs, you can always conservatively manage a possible solitary pulmonary nodule. All cases do not need excision, is what you have to basically remember. Now, what do you see? Rat tail-like appearance, which is a classical feature of achalasia. So, what is one of the important complications of it? There is a higher than normal incidence of esophageal carcinoma in the people who are having achalasia, is what need to be remembered. A 76-year-old coming from Warangal has a back pain, hypertension, and a CT scan, what is it showing? Presence of a aortic aneurysmal, dissecting aortic aneurysm. So any dissecting aortic aneurysm, what will it do? The branches of aorta, like mesenteric artery, they will suffer ischemia whenever aortic aneurysm is dissecting. So what do you need to basically expect? Ischemia of the colon is a possibility in his given clinical scenario. Conservative management instead of reconstructive arterial surgery is generally indicated for which important sign? If neuropathy or ulceration or nocturnal foot pain is there, it is called critical ischemia. So there no more conservative. If it is only state of claudication, then you can still use. So once more, brachial ankle index. What is the normal value? At what value you will find different symptoms? Favorite question in the state MD entrance question bank, right? So there is another similar kind of analysis for the last 10 years of APPG papers. Examiner's eye will fall on which topics preferentially. Most of the times, all examiners' eyes also 80% of times fall on similar things. But some examiners will have strabismic eye. So they will look at the topics which are little ajeeb for that entrance, 10-15%. So when we analyze each question bank separately instead of commonly, there is some more smarter intelligence. The whole idea is read little and get good rank. Read little, spend little time in preparation, but still get good rank. That is the whole purpose of the life, no doctor. Do all sins, still how to get moksha. So that is the whole purpose. Why there will be such a big crowd for a Pushkaram? Because people think one dip will take away all sins they have done, stabbing the other man and hijacking other man's wife, or maybe when that fellow didn't get seat, you went in that vulnerable moment and hijacked his fiancée. All those sins will be washed away with one dip. So preparation also, what all we did in the past is forget about it. Now what is the simple few things that we read, still get in the top 100 ranks. That entire world think that last 5 years we had been reading a lot. So honestly also that is true. Why we should read more when we can actually have a chance to read less? 21-year-old from Bijapur, he is alert and fully oriented, but witnesses to an accident report of unresponsiveness after an injury. A neuroimaging is shown. This kind of imaging is epidural hematoma, which is arterial, where there is a lucid interval. History of trauma. Whereas subdural is a crescentic shaped bleed, which is venous bleed, without history of any trauma, no lucid interval. Presents like dementia in an elderly man. That is what you need to remember about subdural hematoma. Now doctor, 18-year-old boy, he has got intact cranial nerves, unable to move his shoulders, but he cannot move his arms or legs. He is flaccid and has a sensory level at C5. Whenever there is a spinal trauma suspected clinically, most important thing when you do in a acute emergency scenario that will decrease the neurological insult. What maneuver if you do will decrease in neurological insult and long-term prognosis will improve. Acute stage may you give intravenous methylprednisolone. That will decrease the chance of the neurological damage that is going to happen if you give it in acute stage. So as a casualty medical officer or a intern in emergency, whenever there is any spinal trauma clinically suspected, first thing is intravenous methylprednisolone is what you have to basically shoot. Now Huntington's disease, what type of inheritance it is? Autosomal dominant. Any autosomal dominant, basically half of the offsprings are at the risk of developing the disease, 50% chances of going to the offsprings. 11-year-old boy, what is this radiograph showing? Typically sun ray appearance, which is classical of osteogenic sarcoma. 39-year-old with multiple sclerosis has bladder spasticity. And what is meant by Lerimit's sign, doctor? There is an electrical shock-like sensation whenever the neck is flexed in case of the multiple sclerosis. Is called Lerimit's sign, is what need to be remembered. Where do you find Dawson's fingers on MRI? Multiple sclerosis, the demyelinating plaques which are pericallosal in their location, they look like the tongue-shaped ones which are called Dawson's fingers, is what need to be remembered. So we have a radiology discussion every week, 2 days in a week, and all those radiology review videos, class videos are all placed in the online video library. We finished neuroradiology, pulmonary radiology and general radiology. So from this week we will continue the radiology review, weekly 2 classes, and totally 30 hours we will revise entire radiology. So those who cannot attend synchronously live class can always have the review on the online video library. Now doctor, cancer of the tongue. If you do prophylactic irradiation of the nodes, it is very much indicated in those whose primary cancer was treated with irradiation, is what you need to appreciate. Tonsils, from where do they develop, doctor? Second pharyngeal pouch. So you must be quite sure this list, I think, already must be there in your 200 pages notebook, the winning notebook, right? So epithelial lining of Eustachian tube and middle ear cavity from pouch 1, epithelial lining of the crypt of palatine tonsil is 2, inferior parathyroid and thymus from 3, superior parathyroid and ultimobranchial body from 4. If this question also you did wrong, means you go back to amoeba in your ascent of phylogeny. So be very sure. September means branchial arch derivatives, pharyngeal pouches, cranial nerve based questions. If you are doing wrong even in September, October means, oh baby, you have to better wake up and start running. Then Killian's dehiscence is what? Triangular area in the posterior wall of the hypopharynx between oblique and horizontal fibers in the inferior constrictor is what need to be remembered. And Perseverance ridge is at the junction of oropharynx and pharynx as a mucosal elevation is what you need to basically remember. Molar pregnancy, what are the complications which occur? There can be thyrotoxicosis because HCG has a similarity to TSH, and pregnancy induced hypertension, ARDS, anything can occur very much because of the molar pregnancy. Now if you look at the beta HCG levels, normally they are supposed to disappear after the suction evacuation of a molar pregnancy by about 8 weeks of time. That's the reason we serially monitor the HCG to know whether there is any recurrence of the molar pregnancy or any choriocarcinoma. To know all that, you will follow the HCG value. Then, can you be able to evacuate with mifepristone, misoprostol regime a molar pregnancy just like you do a unwanted pregnancy? You cannot. If you try to do that, it will typically lead to profuse bleeding. That's the reason we don't do that in case of molar pregnancy. So what is vasoprevia? Vasoprevia is fetal vessels lead to development of encroach into the placental implantation and contribute for the bleeding. Antepartum hemorrhage is what need to be remembered. Then where is cesarean hysterectomy is indicated? Whenever there is an accreta where the implantation is deeply into the myometrium, then that is an indication for hysterectomy is what need to be remembered. McAfee is the conservative regime for management of placenta previa. So where is it basically not indicated? It is not indicated if there is any profuse bleeding, if the fetus is dead, or if the pregnancy has reached 38 weeks, it is not indicated. But if there is any IUGR placenta previa, then you can continue the conservative regime of McAfee is what need to be remembered. So what is McAfee's regime? Dr. Shilpa must have taught very well in her online video library review classes. So please take a chance. And by now, obstetrics, 56 topics in obstetrics. You might have chewed them, assimilated them and ready for radiating them any moment. Am I right or wrong? You are still struggling. What is mentoposterior diameter? What is android pelvis? Is it android anthropoid same? And going through the datta to check that. Hope you are not doing that. Right? 58 topics only you need to read. 58 topics require 58 half an hours. 28 to 30 hours. 3 or 4 days. You go into reading room and come out with a ring around you, obstetrical ring of jnana. Obstetrical jnana must be there when you come out. If you are taking 15 days obstetrics, oh baby, you are in an obstructed state. Don't do that. 4 days, more than 4 days, if the sun rises and sinks on a laboring PG aspirant preparing for obstetrics means they are not reading obstetrics at all. So be sure what is Tilland's forces, Piper's forces, Morris's simile-Wheat maneuver, what is Pinard's maneuver, what is Loveser's maneuver, tap, boom, boom, boom. You must be ready and come out and say, oh, this obstetrics, it's so easy. 30 out of 30 is what I am going to make it, is what you should tell boy. So then a multi-gravida presents at 32 weeks gestation, type 2 placenta previa. Of course, it is easy to say that, little difficult to really practice. But let me tell you, obstetrics is achievable. And there is a breech presentation. What is the best treatment in this scenario? Elective cesarean section. One of the indications is type 2 placenta previa with a breech presentation is what you need to basically appreciate. Then for a placenta previa, which tocolytic is safe to prevent preterm labor? Max sulfate is the best tocolytic that you can basically use, is what need to be remembered. Why? Why not? Why not others? Ritordrine or beta agonistic agents. Beta 2 agonistic agents will relax the smooth muscle of myometrium and decrease the chance of a preterm labor, as all of you know, like terbutaline, etc. Why not they? They can lead to tachycardia. They will not only relax the smooth muscle of the myometrium, they will relax the smooth muscle of the blood vessels. Vasodilatation. Reflexly heart will go into tachycardia. Because the vasodilation, patient goes into hypotension. Hypotension means the baby will cry, oh mommy, where is my blood? Why are you taking this beta agonistic agent? The baby will be crying. Why? Because He was listening what all the pharmacology you are studying while in the first trimester, while he is inside the womb. So he will say, no, don't take Ritodrine, don't take beta mimetics, mommy, my blood flow will decrease, my flow to the uterine placenta will decrease, he will cry. Be very sure. So, a woman 34 weeks with abruptio in the early labor, fetal heart sound is not heard. So, what is the management? So, you need to basically rupture the membranes and start syntocinon drip and then evacuate the baby. Deplaning of the baby must be done because she is in early labor, you should hasten the labor, fetal heart sounds are not heard, so it is in a very vulnerable state. The fetus is what need to be remembered. So you need to expedite the labor by doing artificial rupture of membranes with syntocinon. So how many days parenteral iron will take, doctor? Around 4 to 8 weeks for the hemoglobin to improve is what you need to basically remember. So exchange transfusion, actually from next week onwards I will bring some 10-15 questions as a spotters in the middle, so that online students also will have some amount of involvement sitting from their home and attending class, so that it will be more dynamic class. So exchange transfusion is required in which scenario? Typically whenever there is any severe anemia with cardiac failure, that is the only indication where you need to do exchange transfusion. So that you want to avoid overloading of the circulation is the whole idea. Now, what is the most risky period in a woman who has got a cardiac lesion? By 32 to 34 weeks, it is like Indian Ocean on a full moon day night. If you go for if you are dreaming of going for a honeymoon to Maldives, plan it on a nice full moon day, so that you can have a beachside candlelit dinner and the oceanic waves will be as taller, twice taller than what you are. So plasma volume also increases and it is peak when it is 32 to 34 weeks. That's a whole problem. Tell me, doctor, MS, MR, what happens to MS, what happens to MR whenever there is a pregnancy? Will both worsen, will both improve, or which worsens, which improves? MS, all stenotic lesions worsen, all regurgitant lesions improve with the pregnancy is what need to be remembered.